Morning, Shaggy. I paused it when everybody was coming back in. So, whoops. Okay, so that should be recording. Yeah, so it's recording now.
And then there's a question about will they be getting feedback on the videos they submit? I assume they're talking about the videos for this project.
I've given some people feedback if I thought that they needed to be redone. So if you didn't hear anything from me, your videos are fine.
Oh, okay. So these are videos people have already shown you.
Yeah, they've all been submitted.
Okay.
Yeah. Okay. Any other questions? Is that good? Okay. Sorry about the recording. Yeah. Okay. I think that was all the announcements. Anybody have any other questions before we plow into this? We're going to be talking about, so the last exam is going to cover shoulder and then elbow, forearm, hand, this lecture here. So it's really just 2 lectures. I am going to send out another modified course objectives list for you. And you might find that there are things on there that were not covered in these 2 lectures. So we might be reviewing some things in spine as it relates to the upper quarter, posture as it relates to, upper quarter. So I may be pulling some things from previous lectures, but I will try to be very clear. You do have a comprehensive, the comp exam coming up. So you still, you have to study for those other concepts as well, but I will try to be very specific with this exam. If I got 50 questions out of just these 2 lectures, I don't think you would like the detail of the questions. So I'm trying to make them a little bit more manageable, if that makes sense. It's hard to get 50 questions from 2 lectures. All right, any questions about the exam or anything before we go full on? We're good? Okay, let's see if I can do this correctly. So which screen, let me share and see where you guys are at. So what are you seeing there, Wayne? Are you seeing the full slide?
I am not. I'm just seeing everybody. I'm seeing your picture and everybody's screens, I guess. I'm not seeing what you're sharing.
You're not. That's so not good.
I was earlier, right up until you. I was seeing the canvas part.
Huh. Well, I don't know what I did wrong. Okay.
Try share screen again.
Yeah. Huh. Let me try. Are you seeing that?
Nothing shifted for me.
No. Well, what the heck?
All right, hold on. Now I'm seeing it.
Okay. And you're
There
seeing
now.
the did you get it slide?
Yep.
Okay. Well, I'm going to try to go to presentator mode. That's a new word for me.
I think that's a new word for everybody.
Presentator. Okay, how about that? What are you seeing now?
I am seeing just the slide.
Okay, perfect. The did you get it slide?
Yep.
Okay, so we're going to just do a little quick review here from the shoulder from last time. So describe the osteokinematics of the clavicle during shoulder abduction. So think about what is going on as the shoulder is abducting. Do you see my arrow move, my pointer moving?
Yes.
No? Yes, okay. So we've got triplanar motion occurring at the clavicle. We've talked about in lab about the elevation component, right? So the osteokinematics of the clavicle include, I'll give you this one, elevation at the SC joint. The degrees here don't matter that much to me. Just the fact that you can identify that this is an elevation of the SC joint. It is an upward rotation here of about 30 degrees of the AC joint. And the clavicle also, if you see up here in the transverse plane, is going to retract 20 degrees. You get some upper thoracic extension as you go into full abduction. When that happens, the clavicle retracts with it, which, you know, makes total sense. The other thing that happens, just happened to, I'm going to regret doing this. Let's see if I can stop share for a second. Okay, the other thing that happens, so you've got the protraction, retraction occurring. The crank motion or the rotation is this motion that's occurring down an axis along the length of the clavicle. So that posterior rotation is guided primarily by ligament structure and some muscle attachments. So that is another component that's important to, now I don't know where I'm going. It's important to be able to incorporate into the movement. If you don't have that rotation, then you also are limited in mobility and you end up with some impingements and things like that. Okay, so I knew I shouldn't have gotten out of this.
Alrighty, it's back now.
And what are you seeing? Are you seeing just your screen?
I'm seeing your slide, not the full presentation mode, but the.
Oh, okay, good. All right. Okay, so I'm gonna not do that again for a while. Let's do,
All right.
There we go. Okay. Describe the interaction of the scapulothoracic and glenohumeral joints during shoulder abduction. So this one's a little bit easier. The glenohumeral joint moves twice as much as the scapulothoracic motion. Remember that. So it's 120-ish degrees of glenohumeral, 60 degrees of scapulothoracic. There's also a posterior tilt that goes along with that upper thoracic extension. So a slight tilt. And that goes along with the clavicle and all of that motion. So in order to get our full 180 degrees, all of those components need to be working correctly. A loss of 180 degrees could be loss of any of those, of motion at any of those joints. And that's something very important to remember. It's not just necessarily the glenohumeral joint, which is what we usually go towards to get full range of motion. We need to consider the others as well. All right. Oh, I'm dizzy now. What are the arthrokinematics of the sternoclavicular joint when you shrug your shoulders? So we're talking arthrokinematics now. It is a saddle joint. So as the clavicle elevates, it is a convex moving in a concave. So in a superior motion of the clavicle is going to be inferior motion at the SC joint. Oh, that is annoying. Okay, so the clavicle motion is elevation. Joint surfaces are convex on concave. Roll and glide are opposite. I don't think I'll do that one again. Therefore, the motion is superior roll with an inferior glide. All right, it is a complex complex joint. So, you know, if you have questions on that, we can talk about that some more. The costoclavicular ligament, which is right here, just lateral to the joint itself, is actually the ligament that's going to restrict the elevation of the clavicle. Very important ligament for control of the clavicle motion. All right. Any questions on those or just reviews? All right, so the elbow is kind of like the knee. It's designed to serve the hand, right? The knee is subject to what's going on and where the foot wants to be. The elbow is designed to serve the hand. So it can bring the hand closer for eating, for throwing, for whatever. But it can also, reach and give us more extension for getting things to where we want them and controlling the motion in different planes. There are 15 muscles that cross the elbow complex. And many of those act on the shoulder and the hand. So they are intimately connected with one another. These are the objectives, the general objectives that we're going to talk about today: the osteokinematics, stabilizing structures, major functions of the muscles. So it's good for you to have a review of the forearm muscles. I didn't have an anatomy review quiz for this section, but it would behoove you to remind yourself of those. We're also going to talk about force transmission. That's very important as we work through closed chain activities and lifting and carrying and things like that. The palmar arches. We want to look at the extensor hood mechanism in the hand, the flexor pulley system in the hand, and how all of that works. Talk a little bit about the differences between extrinsic and intrinsic, and prehension. How do we grab things?
So Kathy,
yeah,
one of the students pointed out we can all still see you even when you share your screen. So if you want to demonstrate something, we see your little window.
Okay.
Well,
it's very small. I get that.
Yeah, it is small.
Oh, you can do the presenter view, can't you? When you guys, you can do, or does that? No, never mind. Just stays a small window. Seems like I can make somebody big one time. Okay.
We can kind of move it around. So if we want to see a little bigger, we can make our screen different.
That's right.
All right. Because I do have a model here I was going to use for later. So we'll see how that works. Okay, so this is that law of parsimony that we talked about in lab. Basically, like I said, the body wants to be as lazy as it can possibly be. It doesn't want to work any harder than it has to. It doesn't want to recruit any more muscles than it needs to. So for a given motion, the body is going to provide the right muscle force. So the elbow extension is a great example. When you go to do something like pushing an elevator button, you are not having to really activate a whole lot of muscles. Your long head tricep does not need to help push an elevator button. It's probably going to be medial head and anconeus. But if you're pushing this heavy cart, you darn betcha you're going to recruit every bit of tricep that you have, which is then going to imply that it has to have a stable surface at the glenohumeral joint, or at the scapula, to allow the tricep to move at the elbow. So you have to stabilize the end that's not moving so that you can get the force that you need out of the other side. And this works through the entire body. We're going to talk about it a little bit in the arm, just because it seems to be more diversity of demand on the upper extremity, but it's throughout the body. All right, so just a quick review so we're all on the same page. The humeral ulnar, this one, the humeral ulnar joint, is normal valgus angle. So normally the hand is slightly away from the body, from 8 to 15 degrees. That's normal. If there is an angle of greater than 20 degrees, we're going to call it an excessive valgus angle, or a cubitus valgus. If the angle is diminished, less than 8 degrees, we're going to call it a cubitus varus. Women tend to have bigger angles than men, just like in the Q angle, mainly because of our, we typically have wider hips and those sorts of things, but there are other reasons. They actually there are some people who have proposed that the proximal end of the ulna actually angulates more and grows longer in a shorter person than a taller person. So They really don't know why. Men are usually shorter than, or women are usually shorter than men, and so that's why they think the angle is greater. That's was proposed by Kari in '99. There's another guy who proposed it was because of increased extension in women over men. So they really don't know why that angle is greater typically in women, but it will be. You can have excessive valgus or varus if there was some kind of trauma, especially as a child at the growth plate. So if you fell as a child before your growth plate was completely formed and fractured your proximal elbow, then you might have an angle that's greater or lesser than normal. It's not usually a real big challenge for people. Doesn't really impair them that much functionally, but it can overstretch the ulnar nerve if they have an excessive cubitus valgus. The nervous system, I say that, and then I think the nervous system is very adaptable. And so the nervous system is going to adapt to a chronic excessive cubitus valgus. So your biggest problem is going to be if it's a sudden onset from a fracture or something like that. You might have some ulnar nerve damage, but in general, the nervous system is very adaptable. The stabilizing tissue, I'm just going to talk, just identify these structures so that we all kind of have them in our minds. On the medial aspect, there are collateral ligaments. So, those collateral ligaments are basically ligaments on the sides of the joints that hold things together. So the medial collateral ligament on the ulnar side has anterior fibers that run pretty much the length of the ulna, in the direction of the ulna. So the direction of these fibers, you guys don't know this already, is going to tell you what they're going to resist. So there's going to be some resistance to distraction or longitudinal traction at the elbow from these anterior fibers. The posterior fibers are kind of triangular shaped. There are 3 parts to it you don't have to really know about, but they are triangularly shaped. A little more support for that valgus force. And then the transverse fibers only run on the ulna. They don't insert on the humerus at all. So the entire complex resists valgus forces and longitudinal distraction. That's its main gig. The lateral collateral ligament and the ulnar collateral ligament are on the lateral aspect of the elbow. And there you go. That's where they run. One is the radial one obviously is going to the radial head. The ulnar one is going to the ulna. I love the way they name ligaments, right? Makes things so much easier. And then the annular ligament surrounds the head of the radius as it spins during supination and pronation moments. Okay. So those are pretty straightforward. The lateral collateral ligaments are obviously going to resist varus forces. So they are most likely to be damaged from a blow to the medial aspect of the elbow. I would be remiss if Dr. Schwartz would get me if I didn't talk about the arthrokinematics of the humeroradial joint. We're going to learn more about this, but it follows the same rules that we've learned all along. You just have to remember which one is convex and which one is concave. So in typically the forearm, the ulna is moving on the humerus. So you've got concave moving on convex. So it's going to glide in the direction that the bone is moving. If for some reason you're moving the humerus instead of the ulna, it's opposite. So this is a pretty stable joint if you think about it. And then the radius is also concave moving on convex. The radius being on the lateral aspect actually helps to provide some resistance against valgus stress because it it approximates the capitulum. So with a valgus stress, the radius approximates the capitulum, and that helps to limit the motion. With an overstress type injury, you can actually get a fracture of that because of the stress that goes through the radial head. The other thing that this picture points out very well is the stability of this joint in extension for distraction. So if you think about hanging from, like hanging down doing a pull-up, the olecranon it's very stable. It wraps around into the humerus. So it's very stable. And, if you think about I don't know what your beliefs are about our ancestors, but monkeys hang from their arms probably more than they walk, right? So this is a very functional alignment for primates because they do hang. So it makes it much more stable. So, I mean, that's something to keep in mind. Look at this as opposed to our knee, which is not a very bony congruent joint. So, so it's designed to help us to hang. So just a little tidbit there. Another thing that's really, really nice is the interosseous membrane. We don't think about it very much. It's kind of the quiet big dog in the forearm, but this is a very important structure to have. The central band is that thick band in between the radius and the ulna. It's at about a 20-degree angle, and that's very important for its function we're going to talk about in a minute. It gets tight with supination. It also is a place for muscles to attach, so it has some muscular attachments in the forearm. Its primary role is to transmit forces between the radius and the ulna. It's a very thick, very strong structure. Very similar, obviously, to the interosseous membrane in our tib fib. The oblique cord is this little dude right here. And you notice it runs opposite the direction of the central band. So it is going to get tight in the opposite directions that the central band does. And basically, it's a small little guy, but what it's going to do is help to limit the migration of the radius being pulled down relative to the ulna. And then the distal oblique fibers are this little bunch of things right down here. And it basically provides stability in a multitude of directions for the radial ulnar joint. So very important structures for the function of the radial ulnar of the forearm. At the end of the radius and ulna, obviously, is the triangular fibrocartilage complex, or TFCC. Oh, I forgot. Yeah, there's okay. C is complex. So the triangular fibrocartilage is it's a structure that helps support the ulnar side of the wrist. So it's got an articular disc right in here. And that's the primary component. So it's a fibrocartilage disc. It's, how thick those are. They're designed for compression. The central majority of, so 80% of it is avascular. Damage to it leads to challenges with healing because there isn't any way to get healing properties, the healing cells in there, except for the chondrocytes. But it is designed to take compression. So, and it also serves to kind of help the radius pivot. So it allows that radius to rotate, take the carpals with it around a fixed ulna. So it kind of sits in there amongst all these other ligaments. It fills space too. If you look at I don't have a wrist attached to my forearm, but if you look at the distance if you think about the cadavers, there is space between the ulna and the carpal, so it fills that space. And then there are multiple ligaments around. You don't need to know their names, but there's a complex of ligaments that also helps to support that disc. So that's a very important component that makes our wrist functional, especially with supination pronation. So if you think about the location of that triangular fibrocartilage complex, when you do a push-up or you push hard against a door, that sort of thing, it is going to be the primary stabilizer of that distal radial ulnar joint. The ligaments that are around it that join and hold the radius and ulna together, in addition to those oblique fibers down there. But it also helps to reinforce the ulnar side of the wrist. The radius is a big, beefy bone down here, right? The ulna is this teeny little, kind of not very defined end. So it's very important to support that ulnar side of the wrist. And it also helps with the concavity of the radiocarpal joint because it also is concave right along with the head of the distal radius. And one of the other things that it does is it helps to transfer force from the wrist, from the carpals, up through the ulna. And we're going to talk about that in a minute. Only 20% of the compressive force that crosses the wrist goes through the ulnar side of the wrist. And if you look at this complex down here, that's not hard to understand, right? The size of this radius is going to take a lot of force at the wrist, the majority of it, 80% of it, 20% through the ulna. So fabulous. So then what happens after this compression goes through this beefy radial bone and this teeny weeny little ulnar bone? You get up here to the elbow, and the ulna now is the larger bone, and the radial head fairly small and not well. It's not very. Oh, the word just absolutely fell out of my brain. It's a small little nub of bone. Not a lot of bony contact on the humeroradial side. So what happens with compressive force transmission? This is an important complex. I love this complex. This whole concept is very important to me. So understand this very well. So the force goes through the radius, big beefy end of the bone. It then takes the interosseous membrane and tightens it up. So the force goes from the radius to the interosseous membrane. That 20-degree angle of those ligaments then pulls the ulna up with it. So the force is transmitted primarily through the radius, and then it's transferred over to the ulna via that interosseous membrane, so that there is more of a shared force that goes through the radial and humero-ulnar joints. So this is really important to save the wear and tear on our elbow. If you don't have this membrane, you're going to have a lot of degenerative changes in the radial head and at the elbow. So very important complex to understand. Any questions on that? I can nip them in the bud now. So what happens with distracting forces? What happens when you carry a heavy suitcase? So I got this heavy suitcase I'm carrying, it's 50 pounds, or I got a 50-pound weight at my hand. The interosseous membrane actually goes on slack. So the radius is going to take a good chunk of this force, and it's going to be helped out by the brachioradialis, which is a shunt muscle, right? So the brachioradialis is going to help prevent the radial head from dislocating from its annular ligament. This little oblique cord is going to get tight. So that's going to help to prevent the radius from sliding away from the ulna. Because remember, the ulna sits really snugly in the olecranon fossa. So it's nice and stable with distraction. So we have to be able to transfer some of that from the radius to the ulna, and that's how we do it. Brachioradialis oblique cord. Okay, so that's a pretty cool complex. We're going to look at the proximal and distal radial ulnar joints for supination pronation. This is another important motion for us to be able to turn our palm up and to be able to turn our palm down for function with our elbow bent. We could do it with our arm out if we just did rotation at the shoulder, but we would only get about half the motion. So we have to add that supination component even with rotation at the shoulder to get our palm all the way up. We can pretty much rotate 306, well, I can't anymore, but maybe when I was younger I could, but you can rotate your hand at least through 180 degrees with supination and pronation with shoulder rotation as well. So when you think about pronation and supination, the axis of rotation is actually going to be the radial head, right? And then it's going to be down to the ulnar head. So the axis is diagonal. It runs from the radial head down to the ulnar head. So what happens is the radius actually turns over on the ulna, right? The ulna just sits there and the radius turns around it. Kind of like ballroom dancers, right? The man just stands there and the woman just spins all the way around him. I just watched him Dancing with the Stars last night. So the muscles that attach on the radius can impact supination and pronation, but muscles impacting or inserting just on the ulna cannot help. So with pronation, the radius and ulnar are basically in parallel, and then when you do supination, that's when they cross over. The pronation in all the elbow positions is limited by bony approximation of radius and ulna. And you also get some tension in the dorsal extensor muscles and ligament structures, but bony approximation is kind of what limits that final movement. So how does this pronation supination occur? It requires movement at both the proximal and distal radial ulnar joints and humeroradial joints at the same time. Restriction in one of those joints is going to limit the full motion, the quality of the movement. So what happens at the proximal radial ulnar joint? The only thing that can happen is a spin, right? The radial head just sits in that annular ligament and spins. At the distal radial ulnar joint, it's a concave moving on convex. So it's roll and glide in the same direction. And stiffness is going to be provided by the ligament structures. So with supination, this is the distal end, and this is the proximal end. You can see this is a concave radius, and it's just going to spin around a fixed convex ulna. The ligamentous structures don't matter all that much at this point, but it's nice to understand which ones get tight and which ones get lax. And then this is strictly just a spin. So there are very few true spins in the body, and the radial head is one of those. Pronator teres is indicated here as one of the muscles that actually is going to get tight with that. With pronation, you're flipping that radius over the ulna, and again spinning at the radial head. So it crosses over. It's a crossing over. Okay, so we're kind of switching to the function of the elbow muscle. So the muscles that insert on the ulna, if they insert on the ulna, they can flex and extend the elbow, right? If muscles insert on the radius, they can flex and extend potentially, but they can also pronate and supinate the forearm. So knowing those muscular attachments is important. Depends on how they fall along that axis, their insertions along that axis, and we'll look at that here in a second. And muscles crossing, acting on the wrist can also cross the elbow. So you obviously have to think about active and passive insufficiency, and stabilizing one end to be able to move the other one the way you want to move it. But they can also impact the elbow. So that's why the forearm is so confusing, I think, because there's just a whole lot of muscles doing a whole lot of stuff. So it is very confusing. So function of the pronators and supinators. To be considered a pronator or supinator, they obviously have to have two features. The muscles have to attach on both sides of the axis of rotation. So potentially proximally on the humerus or ulna and distally on the radius or hand. And the muscle must produce a force that acts with an internal moment arm about the axis of rotation for pronation supination. We're going to look at that here in a second, because that moment arm thing throws you all into a tizzy. And there's also an associated with shoulder internal and external rotation. And we talked about that, combining the pronation and supination with shoulder range of motion, you can get pretty much 360 degrees of supination and pronation. So if you just, like I said, if you just kind of stick your arm out and you start in a fully pronated position, if you supinate your hand and then externally rotate your shoulder, you can almost get it back to, well, you guys probably can't. I can't, I just cramped up. So you can get nice functional motion up, but you have to combine it with shoulder to get more than 180 degrees. So this is that axis of rotation and moment arms that we were just talking about, because I know that's your favorite thing to talk about. So this is the axis of motion right here, right? This is for supination. So I'm starting in for pronation. So I'm starting in a supinated position, and any of these muscles cross the axis, and as long as they insert distally on the radius or the hand, they can impact supination. So bicep, supinator, extensor pollicis longus, and extensor indicis are the three indicated here. The one with the best FY, the moment of pull, the direction of the moment arm, is supinator, right? It is more perpendicular to the axis of motion than the others. So it is a very good supinator. It's going to kick in for pretty much any sort of supination that we ask it to do. So that's one of our go-tos. These others can help if we really need help. So if we really are, if we have a doorknob that's really stuck, if we have a screw that's really tight, we're going to draw in some of the others. Bicep actually has a really terrible line of pull. And that's why it really, when you have it in this pronated position, it has a terrible line of pull. It's better when you get it, the hand more into a supinated position. That's when bicep is going to act a little bit better. For pronation, if you're in a supinated position and you want to move to pronation, the muscles that cross that axis of rotation are pronator teres, flexor carpi radialis, pronator quadratus. And just by looking at this, I was going to ask you guys, but I'm going to answer for you. Just by looking at this, the muscle that has the best line of pull, so the best FY potential, is pronator quadratus. So it is your kind of your go-to pronator muscle. You get basically 25% greater isometric torque from supinators than you do pronators. They have a larger cross-sectional area, and it's just a stronger motion. Supination is a stronger motion. So let's think about tightening a screw with the right hand versus the left hand. If you're a left-handed person, right? If you're a right-handed person, you're tightening a screw, you are moving into supination. So that's a very strong position to move into. If you are loosening the screw or unscrewing the screw, right? That's pronation. So we think about a left-handed person, they actually have to rely on their weaker motion of pronation to screw in a screw, um, rather than with their stronger supinators. So that can be challenging for folks who are left-hand dominant, to screw in a screw. It's just not as efficient, a little more of a challenge. So here's that pronator teres, most active and consistently used pronator muscle. It is basically perpendicular to the axis of rotation. It really doesn't do anything else but provide stability down at the distal radial-ulnar joint. Elbow position doesn't matter. It's going to pronate no matter what position the elbow is in, flexed or extended. It's going to work whether there's a light resistance or a heavy resistance. And it's going to work whether you're slow or fast with your pronation. So it is, anytime you're pronating, you can bet pronator quadratus is involved. Again, it compresses the distal radius and ulna together to give it some stabilization. It also helps to guide the radial ulna through its kind of its natural arthrokinematics. So the gliding of the radius on the ulna. Another pronator is brachioradialis, but it also is a supinator. But it's only able to do those things, so it can only supinate from a pronated position to neutral. So if you start with your hand pronated and you want to pull strongly on something, your brachioradialis can take you to neutral, but then it is no help. At that neutral position, it is not crossing the axis of rotation anymore. If you want it for pronation, you start in a supinated position, it will help you pronate to neutral, and then it's going to kick off again. So because of its position and its line of pull, it's only good to get you back to neutral. I just jumped in. Okay. It is really going to be only helpful with resistance too. It's not going to help with just small movements. All right. Why am I not? Okay. All right. So let's look at elbow flexors just kind of as a group. We've talked about these quite a bit, so we're not going to dilly-dally too awfully much. But the primary elbow flexors are brachialis. Its only function is to flex the elbow. That's all it does. And why is that? Because it does not insert on the radius, right? So it doesn't have any impact at all for pronation supination. It generates the greatest amount of force of any muscle crossing the elbow. So it's not affected at the shoulder, not affected at the elbow. It is a one job guy. It's going to be active at any speed of flexion. It's going to be active with or without resistance. It's your go-to. The biceps, obviously, is going to be an elbow flexor, especially long head. Well, and short head too, right? It crosses over onto another, across a joint. So you're really going to be just using that when you have a faster speed or more resistance, that sort of thing. It is the primary supinator when you are really needing supination strength. It will not fully activate in pronation though. So if you're in a pronated position, it has a terrible disadvantage, and it will not fire fully, even with resistance. So if you're pronated and you try to flex your elbow, the bicep, you just don't feel it kick on like it does when you're out of that pronated position. Brachioradialis is only going to be kicking in with resistance for elbow flexion. It is actually the longest of all the elbow muscles, and it divides the flexors and extensors. So it just kind of has that central line of pull. That's why it doesn't do pronation, supination in a lot of different directions. And then pronator is only active in neutral or pronation. And it's only active with resistance for flexion when you are flexing the elbow. So pronator teres does cross the elbow. It can help with flexion, but it is definitely not your go-to. It's one of the, it's only going to kick in when you really, really, really are trying to generate some elbow flexion force. All right. Okay. So the elbow flexor torque are flexion torques for the elbow are 70% greater than extension torques. And it's 25% greater in supination. And that's because big dog bicep is much more effective in supination, right? So that is going to be your real force generator. Your maximum flex torque angle is going to be right around 85 to 95 degrees of flexion. So this is stuff we've already kind of talked about when we talked about the moment arms for these muscles. And they do have the moment arms on here for this position. And those are some pretty good moment arms for muscles. You know, we have a huge disadvantage, but they have a nice advantage at 90-ish degrees of flexion. Okay, so let's think about what it means to be a synergistic muscle, to help a muscle to be more effective as it goes through its motion. So if we think about the deltoid in relation to the bicep. So the deltoid extends the shoulder when pulling a heavy load. So let's say you're dragging your poor dead professor across the floor after you clocked him in the head. So you're pulling this heavy load. As you pull, the elbow flexion basically reduces the length of the bicep, right? So you get closer to active insufficiency of the bicep by flexing the elbow. And so it's going to decrease, and your contraction velocity decreases, right? So you're pulling this heavy load, and the bicep is not functioning extremely well as it flexes to its shorter position. But your max output is greater, right, when the velocity gets closer to zero. So you're pulling slowly because you generate more force with a concentric contraction with a slower activation, right? So deltoid actually can help because it is going to help extend, posterior deltoid is going to help extend the shoulder as you pull. And when you do that, you lengthen the bicep over the proximal joint, and it improves the efficiency of bicep, right? So you avoid that active insufficiency of bicep by having posterior deltoid kick in, extend the shoulder, and give you more ability to use the bicep. That makes sense? So when you think about, when we talk about what synergistic muscles are and what agonists and antagonists are, there is some, I mean, that's part of the synergistic cooperation that muscles have. And the body just does this. Our neurological system just does this, right? Last time you did tug of war, right? You're pulling back like this, right? Your shoulders are extending. I don't know why people keep jumping out of the, are people getting kicked out of the meeting? Huh, I keep having to let people in. Okay. All right, so let's talk about elbow extensors. These are fewer and far in between. So triceps, medial head is going to be recruited first. And typically when it's low resistance, slow elbow extension, because it's a little more efficient. It just crosses the one joint. Long lateral and medial are going to kick in when resisted extension or quick extension is required. So your first go-to is medial head. And coneus is also going to be active in all extension and resistance. And it also helps to stabilize the pronation supination because it inserts on the ulna, it crosses the humeral ulnar joint. So it provides some stabilization as the ulna is being pulled on. Okay. So in low load trunk or elbow extension, we're looking at medial head and anconia is probably kicking in. If long head of tricep kicks in, then you've got to have bicep and deltoid and all kind of stabilizing at the shoulder. It gets to be a mess. So what is the benefit of the deltoid flexing the shoulder during elbow extension when pushing open a heavy door? Right, so as you push open a heavy door, you start with your elbows at your trunk, let's say, and you push, your elbows extend and your shoulders flex. Right, so you know anterior deltoid is helping with that. So again, it's kind of the same situation that we had with the bicep. It's going to minimize the rate and the amount of shortening for the long head. And that shoulder flexion torque helps to neutralize the active insufficiency of the tricep. So a lot of synergistic activity going on at the shoulder as you are doing forceful movements. If it's a light door, you know, you probably don't need that because you're not kicking in the long head of the triceps. So deltoid comes to the rescue again, right? Deltoid is helpful for elbow flexion and extension under resistance. Oh, dang. Okay, let's take a break. I got on a roll. Let's do a 5-minute. I have 9 o'clock, so I'll start again at 9:05. Let's see. I'm going to pause recording. Sorry about that earlier. All right. So we, you know, me and my little muscle chart. So the axis of motion at the hand. So now we're at the wrist. Capitate being the axis of motion basically at the wrist. I wanted to share this with you because I think this really helps to kind of understand the control at the wrist. So with this one, you've got palmar up here. Oops, let me come over here. Palmar up here, dorsal down here. So your muscles that flex the wrist are going to be on the in this quadrant, 2 quadrants. The muscles that extend the wrist are going to be in this quadrant. So if I ask, or if you notice a patient come in and they are able to, when you ask them to flex their wrist, they do this, right? So they kind of radially deviate as they flex their wrist. They can't do pure wrist flexion. Then you would assume there's a weakness in which muscles. If they flex and radially deviate, they are likely lacking strength in the muscles in this quadrant, the flexors and ulnar deviators, right? So you would want to check the strength of their flexor carpi ulnaris primarily. The flexor digitorum superficialis profundus are very close to the axis of motion, so they could go either way. But your flexor carpi ulnaris is the one, because it's the farthest from this axis of motion, right? That is likely the one that has been damaged or neurologically impacted. Okay, same thing with extension. If somebody extends and they extend towards ulnar deviation, let's say, so as they extend, they kind of go to ulnar deviation, then they're going to be lacking some muscle control on the radial side of their wrist. So extension and radial deviation. So one of these muscles could potentially be impacted. This, I don't tell you to memorize things very often because I think, gross anatomy kind of lays the foundation for that. But this, I think, is a chart that's very helpful to have, kind of in your memory. It will help you in the long run as far as you dealing with wrist and hand problems. So if you want pure wrist flexion or extension, there's no one muscle that really does that. There's a cooperation among muscles, especially across the wrist. So quality of movement is going to be important to pay attention to. All right, so here's a practice question for you. What muscles of the wrist perform the cocking phase of hitting a nail with a hammer? Which muscles are the farthest from the AP axis, and why do we care? So the muscles that they've kind of laid these out for you here. So if you're cocking your wrist to in preparation for nailing this nail, you're going to be looking at radial deviators. So extensor carpi radialis longus and brevis, right? Abductor pollicis longus and extensor pollicis longus and brevis on the extensor side, right? So you also have flexor carpi radialis helping as well. So extensor carpi radialis, longus and brevis, and flexor carpi radialis work together to do this kind of radial deviation motion. And that's, that's very clear to see when you look at this chart. That makes a ton of sense, right? There they all are. So extensor carpi radialis brevis here and longus here, extensor pollicis longus. And then you've got flexor carpi radialis and abductor pollicis longus. So all of these are quite a bit of distance away from the AP axis. So they're going to be very efficient for producing radial deviation. All right, that makes sense for everybody. No questions? Okay, tissues that contribute to movement. When we're looking at the hand, and this is a very complex structure, and we're really just going to be talking about the general mechanism of it. So I don't expect you to understand or to remember all of these components. If you decide that you want to work with hands and be a hand therapist, at that point, it will be very important for you to know this information. But at this point, just understanding how the system works overall, I think is going to be sufficient for you. So in the fingers for flexion, the tendons move through fibrous digital sheaths. So as the tendons come from the carpal tunnel, flexor digitorum, profundus and superficialis, they go to each of the fingers, and then they are enclosed in these digital sheaths. And these reduce the friction for the tendons. They also provide nutrition because there's some fluid that keep the tendons hydrated. And they enclose those the flexor digitorum, superficialis, and profundus tendons. And I think this is interesting to see on this picture. I don't have another picture later that talks about it, but the superficialis is obviously the most superficial, and it is going to go just to the proximal phalanx in the middle phalanx. The flexor digitorum profundus is the only tendon that goes to the distal. So if you have the ability to flex your distal, your DIP joint, right? If you can do that, I forgot where the camera was. That is profundus doing its job. If you can't do that, and I ask you to flex this and you end up doing this kind of thing, then profundus is likely ruptured or not functioning. The other thing about these I wanted to point, well, I think the next picture shows them a little bit better. But they talk about these, the pulleys. So they name the pulleys by A's and C's. C's is cruciate, and the A's I think are annular. Yes. So when I went and had my, I had a problem with my thumb. I had an infection in my thumb, and so the OT that I went to see is a hand therapist, and I was really intrigued because she was talking about the pulley mechanisms and all that. I went, oh my gosh, that's so cool, to actually see that. So anytime you're injured, what I have learned, don't be sad that you're injured. Just add that to your empathy for your patients and your bag of tricks, and it just gives you more experience in the world, right? So now I know that these matter. If you're a hand therapist, it matters what annular ligament or cruciate ligament you're talking about. So just kind of understand that structure. And this is what they do. This is how they function. So you've got these retinacular flexor, the retinacula bind these flexor tendons as they move along the phalanx. So the cruciate pulleys are these ones that cross, right? Cruciate means cross. And the annular ones are the ones that are just going side to side. And this is how they are numbered, right? Which phalanx they're on. And here's the flexor digitorum superficialis and profundus tendons moving through those sheaths. So the importance of this is if you have a rupture in one of the sheaths, you end up getting this bowstringing of tendons, and you lose the ability to effectively flex your finger at each of the joints. So you're going to see, you actually do see, you can Google this if you want to, but you can, when they flex their finger, you can actually see that bowstringing at the joint. So it's definitely something that you can identify. So that's a ruptured pulley if somebody has ruptured their pulley. And you can, I just wanted to point out here too, this is your moment arm. So it's providing that effective moment arm at this joint. When you lose that tendon, your muscle, your tendon is at a huge risk for further injury. All right, so that was flexion. Now we're going to talk about extension through the dorsal hood extensor mechanism. And this is a fascinating mechanism as well, because you actually are going to be using intrinsic and extrinsic muscles to perform these movements. And the beauty of the tendons in the hands are you don't have a you don't have a really muscly hand, right? If our tendons didn't go to our fingers, if we had to have muscles go to each of the fingers, we'd have like these big old sausage fingers, and we wouldn't be able to do fine motor stuff. So it's a wonderful thing that the tendons exist and that these mechanisms exist so that we can use our fingers for fine motor control. So the dorsal hood mechanism is designed to optimally, again, align the tendons for extension. It allows that extensor digitorum to transfer extensor force to the entire finger, right? So your extensor digitorum muscle belly is in your forearm, but because of this mechanism, we can fully extend those fingers. We can identify which joint we want to move. You know, we have that flexibility and that control. The smaller muscles in our hand, the intrinsic muscles, the interossei and the lumbricals, attach to the dorsal hood. And because of that, they can also assist with finger flexion. I'm sorry, extension. So, good Lord. So they help with MCP flexion, but they also help with digital extension, extending at the phalanx. So here's the dorsal hood expansion over an interphalangeal joint. So the extensor digitorum tendon comes in through the sheath, extensor hood. These ligaments attach down here to lumbrical and interossei tendons. And then the central tendon actually the main tendon splits into lateral bands and the central band. So the central band goes to the middle phalanx, the lateral bands go to the distal phalanx. So when the interossei and the lumbricals are, when the MCP is in extension, the lumbricals and the interossei are actually in a position to tug on this ligament and help to extend the DIP and the distal tendon and the interphalangeal tendon here, or the interphalangeal joint here. So it's a wonderful mechanism where those muscles are able to do both flexion at the MCP and extension at the digits. And this picture here shows you a little bit better how that tendon comes down, splits into the lateral bands, and then joins back together into the terminal tendon. And I'm assuming you guys did some of this in gross anatomy. You know, this should be kind of a review for you, but that's the dorsal hood extensor mechanism. So back to the interossei and the lumbricals. If the intrinsic muscles only are functioning and you have no extrinsic muscles firing at all from whatever reason, maybe there was an injury of some sort, this is the position that you're able to maintain. So the intrinsic muscles flex the MCP joint and extend the DIP joints, the DIP and the PIP joint. So that is the position that's the intrinsic plus position of the hand. Fingers extended, MCP flexed. If the intrinsic muscles have suffered a nerve damage of some sort, and only the extrinsic muscles are functioning, then this is the position of the hand. It seems like it's there's a generic name for it, monkey fist or something like that. But so basically you get that hyperextension at the MCP joints and then flexion of the DIP and the PIP. So you lose the ability of that dorsal hood to extend the fingers. So this is extrinsic plus, or you might hear it called intrinsic minus. But either one, the implication is the lumbricals and the interossei are no longer are not able to assist with this motion, and this is the position that you're going to see. So it's a simultaneous contraction of all those extensor muscles in the hand: extensor digitorum, flexor digitorum superficialis, and flexor digitorum profundus. All right. So not a very functional position of the hand at all. And these are extreme examples from long-term use, potentially nerve damage or something. And so these are some chronic. I found some fairly extreme position or pictures. A new injury wouldn't be quite that extreme. And so, because just like the shoulder, our neurological system, our motor control system, coordinates movement to do the things that we need it to do. So when you're making a fist, when you're grabbing onto something and making a fist, your wrist flexors are creating a torque. So the muscles that flex your fingers also flex the wrist. So they're creating a torque at the wrist in order to counteract the wrist flexion so that your fist is maintained and relatively neutral. The extensors have to kick in to block that flexion. So you're going to have extensor carpi radialis brevis kick in, hold the wrist in slight extension so that you can get improved grip with the flexor digitorum profundus and superficialis. If we let it flex, we lose force generation because of active insufficiency. So that coordination across the wrist with the wrist flexors and extensors allows us to have the correct force generation of our fingers, our max grip strength. And the max grip strength is slight extension. So these are the moment arms for those muscles, and they're pretty equal. So as they generate that wrist flexion here, the extensor muscles are able to generate an equal force for extension. The optimal wrist angle is about 30 to 35 degrees of extension, and then there's also a slight component of ulnar deviation at 5 to 15 degrees for optimal grip strength. So that's kind of how we posture. Grip strength and wrist position, again, we've talked about this when we talked about active insufficiency. But this is what it looks like, if we're looking at grip strength with the wrist. So if the wrist is maintained in flexion, if the wrist extensors are not able to counteract the pull of the flexors, you're going to get you can kind of see here, you've got, this is your force gauge. You've got, moderate strength. As you go to more neutral wrist extension, your ability to generate force increases. And then as you go to about 35 degrees of wrist extension, that's where you max out, 30 degrees. If you go further into wrist extension, you lose the ability to generate as much force, and that's passive insufficiency. Active insufficiency, sorry. Yeah. So basically, it's not really active insufficiency. Sorry, I misspoke. It is the muscles being just too long. They're in a fully lengthened position. So if you think about that length tension curves that we talked about way back in the beginning, the length tension curve, when the muscle is fully extended, it can't generate as much force because those sarcomeres are too far apart. Okay, so that's the phenomena that you're seeing here. Okay. So if a wrestler is in a quadruped position, so that's on all fours, and his opponent pushes on the lateral aspect of his elbow, what direction is the force, and what ligament provides stability against the stress? I'm gonna let the chat go for a minute and see if anybody has any thoughts on this. So what direction is the force, varus or valgus? Pushing on the lateral aspect of the elbow. Anybody out there? There you go. Nice job, Reagan. Yes, valgus. It's a valgus force on the elbow. So what ligament provides stability against the stress? And you can just talk about the general ligament complex. What general ligament complex is going to provide stability against the stress? You can just do the general collateral ligaments. Yep, medial collateral ligament. So if you have an injury from a force from the lateral aspect, you would expect that the MCL is likely damaged, right? Good job. Okay. Y'all are out there, by golly. Okay, so palmar arches, just like in the foot. The palm also has arches that are designed to help us with grip, to help us to adjust our hand position for a variety of needs. The proximal arch is through the carpal bones. So it's going to be right up here in our wrist complex itself. The keystone of that one is the capitate. So if you put capitate in the middle, that's the keystone for that one. And it's the distal row of carpal bones that actually forms that arch. This one is very rigid. If you think about the carpal bones, they are held together pretty tightly with ligaments. So there's not a lot of mobility that occurs in the proximal transverse arch. It primarily is maintaining its position because there's some important tendons that run through that space. So we really don't want that proximal transverse arch to flatten or to lose its volume. The distal transverse arch is going to be at the MCP joints. The keystone is somewhere here between the second and third MCP joints. So that's kind of the central aspect of that. That's what things move around. So for the distal arch, if you move your hand like this, you try to make that arch greater, you're going to be moving around the second and third carpals, right? So the third one doesn't do a whole lot. It just kind of sits there and lets the world move around it, right? This allows for an adjustable position for the MCP joints to allow the fingers to get in a position that we need them in. It's a very mobile arch. So the distal arch is what helps us to position our fingers. Then there's a longitudinal arch that runs the, oh, that's what I was talking about. Okay. Oh, I got ahead of myself. So the longitudinal arch is the one that actually allows us to kind of move this way. Then there's the one that gives us the palm structure longitudinally. And again, that's the second and third MCP joints. So that's kind of the central aspect of the hand. So the distal arch runs across the MCP joints, gives us mobility, allows us to adapt our hand for grip. And the longitudinal arch gives us structure through the palm. And all of these arches allow us to increase the surface contact. So allow us to get as much surface contact with an object for a stronger grip and for some sensory input. Different types of prehension. So prehension is the ability to grasp or pinch. It's what sets us apart from the rest of the animal world, right? Because we have a thumb that allows us to do very different and important things, like tip to tip and pinch to pinch and or pad to pad and that sort of thing. So there are two forms of prehension we're going to talk about. Grip is when all the digits are used. So you're going to grab a ball, you're going to grab a can, you're going to grab a pole. Pinch is thumb and index. So those are the two different distinctions. And we're going to talk about each of these in light of power or precision. So are we doing it to generate a strong grip, or are we doing it for fine motor control? Power grips are used for stability when large forces are needed. These are grips, so it's all of the fingers involved. And you can have a spherical grip or a cylindrical grip. So the spherical grip is going to be grabbing the ball. So think about sphere as a ball. So that's a spherical grip. Cylindrical is like grabbing a can or grabbing onto this hammer like he's got. So that's your cylindrical grip. And they're very different. And it's because of that distal arch that we can do a spherical grip or a cylindrical grip. Typically for these, the wrist is in neutral, but remember that slight ulnar deviation gives us a little bit more power. So you're going to have it in a neutral to slight extended position and slight ulnar deviation. And the important thing is the thumb will come around, it will flex, and it will adduct. And that closes that grip like a vice. It brings that thumb in around the object so that you can hold it firmly. Without the thumb, we can't do that spherical grip at all. Precision grips are when we want to control or manipulate something with all of the fingers and the thumb and fine tune things. So this is more, like knobs and buttons and like turning a knob or a control, that sort of thing. So the thumb is partially abducted and the fingers are flexed. So you've got the thumb abducted away and you're basically opposing the fingers and the thumb around whatever object it happens to be. So that's precision. Looks like the cylindrical grip, but we're not gripping firmly. We're actually just trying to bring fingers to thumb. So now we're talking about the pinch grips. There are three that we typically look at, and we test for these with pinch gauges and things like that. So one of them that we use frequently is called the key pinch, or the lateral pinch. So you're bringing your thumb basically to the side of your index finger. This is good for keys because you can hold that pretty tightly to turn the key in the lock. So it's a nice stable position to manipulate that object with some power. So when you need a little bit more force with a pinch, this is a good one to do. And it is a little bit strong. You've got a nice stable finger and you're bringing the thumb, you're flexing the thumb basically into the finger. The precision pinch, you can have tip to tip or pad to pad. And this is for fine control between the thumb and index finger. So you're using a pen, you're using a paintbrush, you're just manipulating your earrings to put your earrings in the morning. So the tip to tip is for skill and precision with tiny objects, and then pad to pad is for larger objects. And I think I probably mentioned it before. I have lost the flexion of my thumb because of that infection that I had. So I can't really do a tip to tip anymore with this right hand. So I was sewing masks the other day, and if I drop a pin on the table, I can't grab that pin anymore because I can't do that precision tip to tip. So I have to use my left hand. So even just a slight loss, I've probably lost half of my motion in that right thumb. Just that can impact how functional you can be. So it is important to have the full motion in your fingers. It makes you much more functional. And then a hook grip. This is a different kind of a prehension grip. It's kind of a specialized one that doesn't require the thumb. So it's all the fingers in the palm. The thumb is not required. And this is a good position if you have to carry something for a long period of time. So a briefcase, a suitcase, books, you carry books like this, right? You kind of hook around them. The thumb can help. You can include the thumb around the fingers if you want to, but it's not required. So this is a nice static position to carry things with. All right, so just a did you get it question. What are the primary muscles involved with just flipping a pancake? What muscle is the primary one? I'm going to open up my chat again and see. So if you're flipping I flip a pancake like this. So I scoop it and then I flip it like that. I might do it backwards because I tend to be a little bit left-handed. So that's what I'm doing. I'm sliding the scooper underneath and I'm flipping my pancake over. So supinator, yes, thank you, Cassie. So that's supinator is the main one. It's a small activity. I'm not going to kick in my bicep. I'm not going to kick in, any of the other muscles that are required for heavy duty stuff. So supinator can do that job. But let's say I have a heavy skillet that I need to flip. I've got a skillet full of water or whatever, and I'm carrying it over to the sink, and then I have to flip it to empty it. So same motion, different story. This one's a little more. Oh wait, I had a question. If we did it the other way, would it be pronator quadratus? Yes. So if you flip from supination to pronation, like I said, I'm kind of backwards. That would have been pronator quadratus. Yes, absolutely. So the heavy skillet, I'm doing it backwards again, right? So I'm gonna supinate to flip it over. So a supinator is going to kick in, but additional muscles that might be participating. Bicep for sure. Yep. So you're going to have bicep kick in because you've got that weight that's there. You probably have brachioradialis from pronation to, yep, Reagan, from pronation to about midway, right? Because it loses its ability once we get to neutral. In addition to that, we likely have some muscles that are also crossing the wrist, like wrist extensors, extensor pollicis longus, indicis. Those all are on that, have that ability to supinate. If it's really, really heavy, we might pull in all of those things. So good job. Okay. So we've got a little bit of time left. I've got a couple of clinical cases I wanted to just walk through with you. Edward Pontaine visits the PT clinic after cutting his forearm with a saw. Sad injury. And Chris, the PT evaluating him, needs to know whether the trauma has affected innervation to his supinator muscle. Chris knows two mechanisms for supination involving different muscles: rapid supination and combined supination with elbow flexion against gravity, which activates the bicep. Slow supination with forearm supported activates only the supinator. How should Chris position the arm to assess only the supinator? I'm going to click through these and get to my other slide. Any thoughts? How would Chris position the arm to assess only the supinator, or primarily the supinator? So we're basically trying to make bicep inefficient here. Got lots of time. What do we need to do to take bicep? Yes. Right, Cassie. So pronate and also flex. So I would say supported, flexed, and pronated. So if you would have her or have Edward with his arm supported on a table, just to kind of take away all the tone that might be there from the rest of the arm, and from holding the elbow in a flex position, and then in a pronated position. Extending the elbow could definitely help because you're making bicep really inefficient then. So yes, you could definitely keep it pronated and extended, because then you're not going to get much carryover either to the bicep. Good. Where should Chris palpate during supination to rule out biceps? What's the best way to palpate biceps? At the tendon insertion, right? At the biceps tendon insertion in the cubital fossa. So you just kind of put your fingers there where you'd expect that bicep, and you can have them, activate so that you can feel that tendon, and then have them relax. Keep your finger there, and then have them do the supination position. Good. Gosh, you guys are actually awake this morning. What muscle activation would Chris expect to feel if the radial nerve is intact? So if the radial nerve is intact, what would the expectation be when we go to supinate the arm? What muscle is innervated by that darn radial nerve? So the radial nerve is right. So the radial nerve is supinator. So if the radial nerve is functioning, you will see the arm supinate, but the bicep will be relatively relaxed. So what muscle activation would Chris expect to feel if the radial nerve has been damaged? So we're in an inconvenienced position for the bicep, but you're asking for supination. So if supinator can't do it, we're going to go up the line, right? We're going to go up to the next opportunity. So you're going to see a bicep activation to do the supination, and it's going to be much more effortful. Yeah. Dan, you're right. So it's not going to be as smooth, right? You're going to see a lot of overflow trying to get that arm into supination. Good. Nice job. Okay. Here's another one. Mrs. Silver is a 58-year-old female, status post, that's what that status post, Colles fracture of the left wrist. She states that she was casted for 6 weeks, and then her doctor told her to perform stretches to her left wrist to regain range of motion. It's been 8 weeks since her cast was removed, and she continues to lack motion in her wrist. So 8 weeks would imply to me that that her fracture is stable at this point. Obviously, you would come with x-rays to verify that, but there likely is not any risk with an unstable fractured joint at this point. Okay, so you're 8 weeks out. At her last visit, her physician added strengthening exercises, but she's concerned about her lack of motion and decided to agree to physical therapy. So here are your objective findings. You've got limited passive range of motion in all directions, but flexion and ulnar deviation are the most limited. You have accessory, when you do your accessory motion testing, so you're assessing the glide, how much motion is happening between at the radiocarpal joint. You find hypomobility of joint gliding motions in all directions, with posterior and radial glides being most effective. So when you try to glide the carpals posteriorly on the radial humeral or radial ulnar joint, this radial ulnar joint, it was very stiff, the posterior glide and the radial glide. Her muscle strength is 4 out of 5. So what do you think would be her initial goal with therapy? Her concern is her lack of motion. Her strength is 4 out of 5. That's actually not bad after being fairly immobilized for a couple months. So I'll give you this one. We want to improve her passive gliding motions so that we can regain her normal physiologic motion. So that roll and glide that naturally happen are not happening because she's had some, her joint has gotten stiff. She just doesn't roll and glide like she needs to from some scar tissue and some joint restriction. So what directions would you start the mobilizations to improve wrist flexion and ulnar deviation, which are the two that are most limited? So which direction would you mobilize for wrist flexion? And you can use palmar or dorsal if you want to. Posterior and superior kind of difficult when we talk about the wrist. So I would put it into, you know, like the dorsal or palmar direction. So which direction? If you want to improve wrist, what did I say? Wrist flexion, right? That's a palmar motion of the carpals. That is a yes, Reagan, nice. So that's a dorsal movement of the carpals. So you've got, and I think I put posterior, but posterior or dorsal. So you're going to glide towards the dorsum of the hand to improve flexion because it's convex on concave. Right. How about for ulnar deviation? Would you glide them towards a radial deviation, a radial side, or towards the ulnar side? Radial or ulnar glide for improved ulnar deviation. So she's not ulnarly deviating. So which way do we glide the carpals to improve that? Radial, right. So, right, Cassie. So radial glides, you're going to glide the carpals this radially to improve ulnar deviation. Again, convex on concave. Right on. Okay. There we have it. Everything you could ever want to know about the elbow, wrist, and hand. Any overall questions for me at this point? The practical exam schedule I'm going to get out today. Ben will be back, so we'll have him back on Monday. Group 1 is going to start at 8 o'clock, and Group 2 will start at 1 o'clock. You will gather in the foyer up here, and don't come too early because you can't have a bunch of people gathering. So really try to be here about 10 minutes before your time, 10 to 15 minutes, and no more than that, because we can't have a lot of people gathering. And then we'll bop out and have you come in after that. All right. Any other questions about the practical? This is like the last time we're all going to be together. I can't believe it. until it happens on Monday. So I'm open to questions. We have 1 minute left. Crystal clear? All right, if anybody needs more opportunity for time slots for exam review, just let me know. I'd be happy to open up more slots. And if it's next week, we can do the Zoom meetings. So, all right. Thank you, everybody. Have a good rest of your day. Happy to help if you have any other questions that come up in the next whatever.
Thank you.
You are welcome. Thanks, guys.